Welcome all to the today's talk discussion. So today we are going to discuss the talk article postpartum ovarian vein thrombosis (POVT). Okay, so it is a rare and postpartum venous thromboembolism. It occurs within 4 weeks of postpartum. 90% will present within 10 days. So when you are given a long scenario, please see at what is the time of presentation. So most often it is seen within 4 weeks, and 90% will be presenting in first 10 days. So right ovarian vein is mostly involved in 80 to 90% of cases. It is potentially fatal. Risk of pulmonary embolism is around 13%. Mortality is around 4%. Incidence is around 1 in 2000 delivery. There is increased risk in cesarean section, especially in twins. So what happens during the pregnancy? We know that the pregnancy is a hypercoagulable state because of the increase in the prothrombotic factors. There is also venous stasis. Normally what happens, the ovarian vein dilatation is almost 3 times near term. There is increase in the blood volume, and also there is a decrease in the postpartum flow through these veins that leads to the stasis associated with endothelial injury. So all these, that is the Virchow triad is there. So that leads to the thrombus formation in ovarian vein. So complication will be sepsis, pulmonary embolism, and extension to the IVC. Okay. So which side is more common? It is the right side that is more common. Right-sided predominance, that is classically it can be asked in the SBS. Okay. Because the right-sided vein is longer, it directly drains into the IVC. There is an acute angle. Then there is a flow which is antegrade, and so the walls are likely to be incompetent on right side, and there is increased risk of stasis and bacterial ascent. Okay, while left-sided vein is shorter, it drains into the left renal vein, and flow is retrograde postpartum. Walls are unlikely to be competent there. Okay, so risk factors: cesarean section increases the risk, twin pregnancy, endometritis, pelvic infection, hypercoagulable state, pelvic surgery, malignancy, estrogen exposure, general VT risk factors. So these are the risk factors. Clinically, you will have the fever. Uh, there will be persistent despite the antibiotics, very typical presentation, lower abdominal pain, usually right-sided, and a postpartum state presenting within less than 10 days. Okay, so patient is less than 10 days with fever, not responding to antibiotics, and right-sided abdominal pain. Okay, there will be other features such as nausea, vomiting, malaise, ileus, palpable adnexal mass seen in around 50% of cases. So postpartum fever, not responding to antibiotics, think of POVT, septic pelvic vein thrombosis, thrombophlebitis. Okay, differential diagnosis will be appendicitis, pyelonephritis, adnexal torsion, tubo-ovarian abscess, pelvic hematoma, peritonitis, etc. Complications: pulmonary embolism, incidence is around 33%, mortality is around 4 to 4.4%. Sepsis is seen in around 13% of cases, it may be fatal. Ovarian infarction can be there. Thrombus extension, this can get extended into the renal vein and then to the IVC. There can be ureteric obstruction leading to hydronephrosis. There may be renal failure leading to long-term dialysis. So from examination point of view, we should remember most important complication or most severe complication here is a pulmonary embolism. Okay. So investigations will show leukocytosis, CRP levels are increased, but this is non-specific postpartum finding. Then urea, creatinine, lactate, blood cultures, these investigations we need to do. Uh, what will happen to the WBC? As mentioned, there will be rise in the WBC count and rise in the CRP levels. Normally also in the postpartum period, there is an increase in the WBC count, so specificity is low. However, if you get the serial rise, that is suggestive of pathology. Normally, in normal postpartum status, it should decline. But if it is rising serially, that will point towards the pathology. So persistent fever plus rising inflammatory markers despite IV antibiotics, think of POVT. Okay. So we have to go ahead with the imaging. If there is no improvement within 48 to 72 hours of antibiotic, we'll think of imaging. Then what are the imaging modalities? Ultrasound is the first line imaging preferred for diagnosis of POVT. So what we will see, tubular hypoechoic anechoic mass. It extends from the adnexa to the IVC, and there will be absent Doppler flow. However, limitation is that it is operator dependent and poor in obese and with because of the bowel gas difficult to find. Okay, so accuracy is relatively low. Sensitivity is around 55%, specificity around 41%. You need not remember this figure. Then coming to the CT scan, around 78% sensitivity findings, you will find the enlarged ovarian vein, low attenuation thrombus, enhancing vessel wall, and perivascular inflammation, which is a key feature. Advantages that it even in obese patient you can find this and shows extent of the thrombus also. Disadvantage is that there is a radiation risk. Okay, so here the second line investigation.
Yes, sir.
MRI best, but it is less available. Sensitivity is around 100%. Differential flowing blood versus acute or subacute thrombus. Okay, there is no risk of radiation. So best test will be MRI, but most practical or commonly used is CT. Initial but least sensitive is ultrasonography test. Okay, so remember what is the question which they are asking. Management, it is the multidisciplinary approach which is followed. Aim is to prevent pulmonary embolism and treat infection. So it is the conservative management or the medical management that is the first line. Antibiotics is given for 7 to 10 days. Continue till the patient becomes afebrile and the WC count reduces. Then broad spectrum antibiotics such as piperacillin plus tazobactam or carbapenem plus clindamycin is used. Anticoagulation, the drug of choice will be low molecular weight heparin. It is preferred antenatal as well as postpartum. Advantage is that no monitoring is required. Heparin-induced thrombocytopenia risk is less and osteoporosis risk is also less. Bleeding risk is around 2%. Warfarin is alternative in the postpartum period. It is safe in the breastfeeding. After 5 to 7 days of postpartum, it can be started. However, it requires INR monitoring. There are drug interactions and higher PPH risk. So, directly acting oral anticoagulants, they are not recommended in POVT. Okay, so thrombolysis is indicated only for massive PV, pulmonary embolism with hemodynamic instability. Okay, so regarding there is some evidence that antibiotics alone are sufficient, but due to the pulmonary embolism risk, anticoagulation plus antibiotics, that is the standard practice. Okay, so pre-treatment workup, we will always do the full blood count, coagulation profile, LFT, RFT, always involve hematologist. Complications are pulmonary embolism, sepsis, extension into the IVC, and maternal death is rare. Okay, then we have seen the first line antibiotic along with low molecular weight heparin. So when to escalate if there is persistent symptoms, extension of the thrombus and contraindication to the anticoagulation. So advanced options will be IVC filter insertion and surgical intervention, that is thrombectomy or vein ligation. Okay. So what is the duration of anticoagulation in POVT? There is no clear consensus in the literature. That is what the talk says. There are different evidences. Resolution has been noted in 7 to 14 days. That is short duration have been mentioned in some cases. Others recommend 3 to 6 months anticoagulation. So guideline which is based approaches by the British Committee for Standards in Hematology that says around 3 to 6 months anticoagulation is required if you diagnose POVT. Okay. So comparison to the DVT, recurrence and mortality risk is similar to the DVT, and duration of treatment is same as DVT management. Okay. So take home message that postpartum ovarian vein thrombosis is almost similar to the VT. Okay. Long-term or lifelong complications, anticoagulation is not required. So it is the peripartum you need to manage this particular case. However, lifelong anticoagulation is not required. Practical approach is to go ahead with the individualize the duration, consider the extent of thrombus, look into the risk factors and the clinical response, and always involve the hematologist in the decision making. So duration of anticoagulation is there is no clear consensus. This we have already discussed. Okay. So next is the inferior vena cava filter. Okay, what are the indications for IVC filter? VT plus there are contraindications to anticoagulation. That becomes the indication for IVC filter. So when there is a VT, but there are contraindication to anticoagulation, that it is the indication for IVC filter, or there is a failure of anticoagulation such as recurrent pulmonary embolism, or anticoagulation is withheld because of surgery. Okay. So these are the and other controversial indication will be free floating thrombus or severe pulmonary disease, trauma, etc. So evidence there is a decreased pulmonary embolism incidence. However, there is no benefit for the mortality, and increased long-term DVT risk is noted. Complications: failure to prevent pulmonary embolism, DVT or IVC thrombosis, filter migration, fracture or embolization, caval perforation, and retrieval complications, including the death, have been reported. Okay, so use only if necessary. Anticoagulant when safe. Remove as early as possible. Retrieval success decreases over time. 90% at 3 months and less than 40% at 12 months, or avoid ongoing bacteremia. So this is to be used, uh, or this is filters are to be removed as early as possible. The next is the surgical management. Indications for the surgical management are the contraindication to the anticoagulation, recurrent emboli despite treatment, free floating thrombus, and non-compliance of or follow-up issues are the indications for the surgical management. So procedures are the ovarian vein ligation, ovarian vein excision, and caval thrombectomy. So it is a multidisciplinary approach, essential due to the lack of consensus. So team approach is required. Obstetrician and gynecologist, hematologist, radiologist, microbiologist, vascular surgeon may be part of the team along with the interventional radiologist. Okay. So coming to the follow-up, routine repeat imaging is not recommended, does not change the management. There is a radiation risk and interpretation difficulty. So anticoagulation prevents extension, not the clot resolution. So provoke VT, 3 months of anticoagulation, repeat imaging, not used to guide the duration. Thrombophilia screening, not routinely required. Once you diagnose POVT, it does not mean we have to investigate the patient for thrombophilia. Okay. Consider only if results will change the management. So when to test? After pregnancy resolution, after the thrombus resolution, and after 6 to 8 weeks after stopping the LMWH. Okay. So POVT alone is not an indication for thrombophilia testing. Recurrence risk is similar to DVT. Recurrence is rare, mostly within first 2 months. What is the contraception after POVT? Avoid combine hormonal contraception. They are UK MEC4. Okay. Safe options will be progesterone only contraception and copper IUD. This can be asked in the SBA. Future pregnancy management, antenatal thromboprophylaxis will be required. It will be given throughout the pregnancy and up to 6 weeks postpartum. Fertility, there is no clear evidence. So take-home message is that postpartum fever plus abdominal pain, not responding to antibiotics, think of POVT. Typically right-sided pain occurs within first 10 days postpartum, commonly after cesarean section. Diagnosis by CT or MRI that will confirm the diagnosis. Imaging indicated if there is a persistent fever 48 to 72 hours despite antibiotics. Best test is MRI. Most practical is CT. Initial but least sensitive is ultrasound. Complications: pulmonary embolism, sepsis, thrombus extension. Management: first line is a low molecular weight heparin along with antibiotics. Low molecular heparin is preferred over the warfarin. Always assess bleeding risk before anticoagulation. Anticoagulation is given 3 to 6 months. Treat as provoked DVT. IVT filter are used only selective cases, only when the anticoagulation is contraindicated or failed, no mortality benefit, there is increased risk of DVT, and remove early when possible. Okay. Then future consideration: avoid uh, oral contraceptive pills. They are UK MEC4. Use progesterone only pills, progesterone only methods, and copper IUDs are permitted. Okay. So this is what we have seen. Doctor, we have few questions. Can you please go through the questions?
Yes, sir. A 28-year-old woman, day 5 post cesarean section, presents with fever and right lower abdominal pain. She has been on broad spectrum antibiotics for 48 hours with no improvement. What is the next best step? A. Continuation of antibiotics for another 48 hours. B. Start warfarin immediately. C. Arrange CT abdomen and pelvis. D. Perform diagnostic laparoscopy. E. Start Thrombolysis. Um, it is to start warfarin immediately. Anticoagulation.
I think we should diagnose it first. Basically, now here you have right lower abdominal pain, fever. She's day 5 C-section. We cannot rule out appendicitis also. Okay, broad
Okay.
spectrum
Then CT
antibiotics
abdomen
she has already
pelvis.
been given. You got my point. Think
Yes, sir.
as a
Then we have to
broad
go for
case. Don't think only with respect
only.
to. Okay,
Okay, sir.
so we should
Yes, sir.
investigate, come to a diagnosis, and then so I think C and D is going to be confusion, no? But there are no
B
typical
and
features
C.
suggestive
Yes, sir.
of appendicitis. They would have given more elaborate features if they would have been suspecting appendicitis.
Yes,
Okay,
sir.
so
In
arrange
this
CT
also,
abdo.
initial investigation they have given us USG no, sir, but here they
Yeah,
have
here
given it as
correct,
CT
correct.
abdomen
CT,
pelvis.
but even that would have been given ultrasonography here. Uh, Persistent fever with right lower abdominal pain. Uh, Appendicitis still will go as a second option, not immediate, means I will not say. So here it is arranged CT abdo plus pelvis. Okay.
Yes,
Persistent
sir.
puerperal fever despite antibiotics, suspected POVT, imaging CT MRI is required for diagnosis. Next.
Which of the following best explains the predominance of right-sided POVT? A. Left ovarian vein has more valves. B. Right ovarian vein drains into renal vein. C. Right ovarian vein enters the IVC at acute angle. D. Left ovarian vein has antegrade flow postpartum. E. Right ovarian vein is shorter. This mostly A, sir, because rest of the statements are wrong. Right ovarian vein is longer. Antegrade
Right ovarian
flow,
enters at IVC at acute angle. Right
it is
ovarian vein,
90-degree angle, sir.
acute angle plus longer vein plus more valves that leads to the stasis. Okay. So left vein has retrograde flow that is protecting.
Yes, sir. A woman with confirmed POVTs is started on LMWH. She asked how long treatment will continue. What is the most appropriate answer? A. 7 to 14 days. B. Until symptom resolution only. C. 6 weeks. D. 3 to 6 months. E. Lifelong anticoagulation. It is D. 3 to 6 months.
Yes, as per this guidance, manage as productivity and standard duration is 3 to 6 months.
Which of the following is the most serious complication of POVT? A. Ovarian infarct. B. Sepsis. C. Pulmonary embolism. D. Hydronephrosis. E. Renal failure. It is C. Pulmonary embolism.
Yes, pulmonary embolism. Most common cause of mortality and can be seen in 33% of cases. Next.
A postpartum woman with POVT has active postpartum hemorrhage. What is the most appropriate management option? A. Start LMWH immediately. B. Start warfarin. C. Insert IVC filter. D. Start DOAC. E. Observe only. It is C to insert IVC filter.
Yes, yes, because anticoagulation will be contraindicated here. Okay.
Contraindicated.
Yeah. Next.
Which of the following imaging modalities has the highest sensitivity for diagnosing POVT? A. Ultrasound. B. CT scan. C. MRI. D. Doppler ultrasound. E. Plain X-ray. It is C. MRI.
Yes,
Best.
MRI has got the highest
Highest
sensitivity,
sensitivity.
but only availability is concern about this MRI. Next.
A woman treated for POVT is clinically improving. What is the role of repeat imaging? A. Mandatory to confirm clot resolution. B. Required before stopping anticoagulation. C. Needed to guide the duration of therapy. D. Not routinely recommended. E. Required weekly. Is not routinely recommended.
Yes,
D.
not routinely recommended. Okay. So anticoagulation prevents extension and not the clot resolution. Okay. Then imaging does not change the management.
Yes.
Next.
A woman with previous POVT seeks advice regarding contraception. Which is most appropriate? A. Combined oral contraceptive pill. B. Vaginal ring. C. Progestogen only pill. D. No contraception required. E. Estrogen patch. It is C. Progestogen only pill.
Yes. COCPs are
IUCD.
contraindicated. They are MEC4, POP, and IUCD are safe. So take home message is that always think of postpartum fever not responding to antibiotics, POVT. Key management triad is imaging, low molecular weight heparin,
Antibiotics,
antibiotics.
anticoagulation,
Watch for pulmonary embolism risk, IVC
embolism,
filter indication, 3 to 6 months of anticoagulation.
anticoagulation.
So that finishes the topic of POVT. Thank you.